All right, hello everyone. This is Sean Rogers with Indiana State University Doctorate in Athletic Training, and today we're going to be talking a little bit about researcher-clinician relationship in terms of practice-based research and a little bit of injury surveillance. As I said, my name is Sean Rogers, and I have 4 other DAT students here with me if they want to go ahead and introduce themselves. Nico, you can start first.
Sure. Hello. My name is Nicholas Merritt, and I'm a student in Indiana State University's Doctor of Athletic Training program as well. And currently I'm the head athletic trainer with Carolina Crown Drum and Bugle Corps. We're on tour now until August 14th. And during the year, I am the graduate assistant, one of the graduate assistant athletic trainers for track and field and cross country at Indiana State.
Thank you. Rachel?
Hi, my name is Rachel Kirkpatrick. I'm also a graduate assistant at Indiana State University, and I work clinically with North Vermilion High School in Cayuga, Indiana.
Thank you. Carolyn?
My name is Caroline Gwindon, and I am also a student at Indiana State in the Doctorate in Athletic Training, and I'm a graduate assistant, and I work at Terre Haute North High School.
All right, wonderful. As I said earlier, we're going to talk a little bit about that whole researcher-clinician relationship. Does anyone want to go ahead and start off by describing their main clinical setting a little bit and what kind of that researcher-clinician relationship might entail if there was to be a little bit of a practice-based research network created?
I think I can kind of start with both of my settings in general, like a combination of both. With the drum corps, like a research clinician setting is kind of open-based. It would be more contact to the athletic trainer or the head medical staff involved, and then the contact with the researcher would basically say, hey, can I collect data with you, or can I collect your injury surveillance data? Can I use it in my research? And you basically say yes or no. And then, so it's more of like you automatically collect for them, and then they give it to you, or they give you something that you can use with your patients, or that you collect on site with them. So it's not like it's your specific project that you're doing, but you're helping someone else with theirs and then reaping the benefits of it in the end to apply the process later on, something similar to that. Yeah. Maybe with the university setting, I haven't had a lot of experience with you know, integrating other researchers within my own practice, but I have taken concepts that I've learned and kind of tried to apply them over time. So,
Rachel or Carolyn, have you had any sort of practice-based research in collaboration with anyone, other clinicians or researchers at your clinical site?
Not currently at my current clinical site. I haven't had that experience, but I think, especially with the kind of network that we have set up with the graduate assistants and the other clinicians, the fact that we are all contracted through a single hospital, I think it gives a potential opportunity to kind of, like Nico was saying with the university, kind of work together and collaborate and utilize other people's research in ours and kind of be basically like a major data collecting opportunity within that. But previous experience, I haven't had any.
I don't have any experience with specific PBRNs or anything like that, but what I have done with my practice, if I have a new technique I'm wanting to use a rated outcome, I'll start implementing it, and then I'll also teach the other clinicians that I'm working with how to implement it, how to use the technique, or whatever other educational matters need to be taken, and then we'll start implementing it with our patient population and see if it's effective with them. So what we're doing is very, very small scale. A good example of that is with voodoo bands. Right now we're trying it with patellar tendonitis, and it seems to be working really, really well. But again, there's only 2 clinicians that are currently using it, and we've only used it on maybe 4 patients. But it's the kind of thing that once we get that clinical experience with it and build our clinical expertise, then we can spread that to other clinicians working in other locations or different settings as well.
So I think that brings up a really good point, and one of the main topics that we're going to focus on today is a little bit about translational research. So translational research, when researchers tend to find correlations and find data points that seem to suggest perhaps a certain intervention might be beneficial for a certain pathology. And then that translational research, when the clinician starts engaging in some of that practice-based research off of the findings of that actual research team. So talking about those voodoo bands, Carolyn, have you are you building kind of that program or utilizing like creating that protocol off of research that you've seen, or is it kind of based off the manufacturer recommendations?
Well, unfortunately, there's not much research at all on them. So what I've done is Kelly Starrett, who is a physical therapist and really big into CrossFit type stuff, he's done several videos on them. So I've watched his suggestions, also read the suggestions that are on their website, and there was one case study that was performed, but it was at the shoulder. I forget exactly the pathology that they were attempting to treat.
Yeah,
so
I've read that
based
one
on
too.
that information and other clinicians that I know that have used the bands, I modified it to the me and the guidelines that have been suggested, and trying to build up evidence for it in my practice.
So if you were to kind of create an ideal relationship between you and maybe your research team, what would that relationship look like in terms of maybe implementing this voodoo bands? How would that relationship between findings in the laboratory affect or work in collaboration with your findings in clinical practice? What would that ideal relationship look like?
So if I was working with a laboratory researcher, I would love to know the physiological changes that are actually occurring in the tendon or muscle or whatever it is that's being treated, and see if it actually is decreasing the inflammation or the swelling of the area that is being treated. And if that is effective, then being able for me personally to track the success of it through patient-rated outcomes or visual analog scale or a region-specific measure or functional measures, and seeing if those outcomes between the laboratory research and then my own research, if they line up.
Okay. Nico, and I had also a question for you. I think in one of our previous collaborates you had, and correct me if I'm wrong, you'd said that there was a kind of either a group or a social media page in which drum corps athletic trainers and healthcare professionals could collaborate on common issues. Is that true? If I'm remembering correctly?
Yes.
So my question for you,
right.
specifically, working in this current setting, I know you kind of flip between two settings. Is there any way that you believe that you could utilize that group of drum corps athletic trainers and healthcare professionals and kind of push translational research with that population? Do you have any ideas that you've been thinking about that? Maybe some research findings that you've read in the literature that you want to try on a big scale utilizing that network?
There has been talk before the season started, so sometime in I think it was either March or April, where there was a mass scale, basically like in previous injury or current injury or health status of drum corps members, and they were getting a worldwide from all of the healthcare providers, all the history that they had previously, and you kind of took your you took your injury data and just sent it to them. So it was kind of like instead of, they have the concept now of like the Collegiate Athletic Association injury data, and then you have that. This is manually done, so everyone sends it in to this one group of researchers, and then they compile the data, and then they have the most common injuries this past year, the most common injuries for this, and then that's where most of the individual studies come from. And I've gotten a couple emails, hey, will you let your people fill out this survey? Hey, will you let me come and talk to your group? And sometimes in the area when they are, because we're traveling. But it does work out in terms of how the communication setting works. And I'm hoping that with the PBR that I'm currently doing right now with the ankle and ankle range of motion, that I can share that with other cores and see if they're going to utilize an injury prevention mechanism to see if ankle range of motion is a predictor of lower extremity injury in the core.
Wonderful. Now, Rachel, it sounds like Caroline and Nico have some projects lined up. Is there any projects that you're interested in, both either doing right now or working on for the future? And what would that look like in your head?
Yeah, I think kind of one of the things that I want to focus on is a little bit more of building up the evidence for like screening tools and those kinds of things, especially since it's just me at the high school and I don't have additional clinicians to work with, and so really focusing on like the preventative side of it and identifying those risk factors. So potential in like utilizing one certain like whole body screening tool and working with that and building up the data for that would be something that I would definitely be interested in. That would definitely obviously take a lot of effort coming from me, and I think in my current clinical practice, doing more of that kind of translational research is probably something that would be the best fit for me. Just because I don't have a lot of people to, like Caroline, having that little bit of a team to collaborate with, it's a little bit more difficult for me.
And similarly to myself, one of the things that I want to focus on, kind of building off what you were talking about, the screening tools, I think that the triple hop for distance, a clinician-rated outcome measure, has a really good foundation for being pushed as a screening tool for some of those lower extremity injuries, especially ones in which you see bilateral differences in strength and power, and even to an extent balance, although that's not as foundational in the literature. Now, I was thinking about this, and when we think about practice-based research, it usually starts on a smaller level. So one or two clinicians starting to tracking their outcomes and seeing if there's trends. Now, for a clinician to take that research, that practice-based research that they might have derived from an actual research study through that translational research projects, in order for them to kind of grow that up, we know that they need to get more clinicians involved. What are some ways that you all think that clinicians can get involved more actively in helping other clinicians with their practice-based research?
I think personally finding your little niches, like how we have at Union with all of our clinicians, that technically we all do work together. We have our own clinical sites, but we work together. But maybe especially if we all can focus on one area of study and finding trends between all of our clinical practices, and then providing that data to like a PBRN or something like that, or just finding trends in our current clinical practice and comparing it to the other clinicians in the area and seeing ways that we can improve or share techniques and things like that.
Yeah, definitely. I think one of the things that we as athletic trainers might not broadcast as well or know profession-wide as well is that we actually have quite a few PBRNs available to us. One of the most notable being the one created by AT Still, the Athletic Training PBRN, which is free to join and connects you to not only kind of a wealth of clinicians who have signed up and are willing to participate in collecting some of these numbers or data for your practice-based research, but it also provides someone who would like to volunteer an opportunity to collect measures for other clinicians. And I think that that's more on a macro level. Thinking about it more on a clinical, like an actual local clinical level for my setting, we have quite a few graduate assistant athletic trainers at Indiana State University, as well as staff athletic trainers. So I think kind of in that bridging step between a singular clinician doing practice-based research and bringing it to a PBRN, that middle step is really hitting that clinic level, where you have kind of that small local level. And I think what that would look like for me is utilizing an injury surveillance system such as Orchard, which one of our classmates presented on, and tracking some of those outcomes. I think one of the biggest barriers of this, though, at least when I look at it, is to get the other clinicians to buy in. Because depending on how difficult and how lengthy whatever outcomes I want them to track is, they might not want to do that because not only do they have to document injury, treatment notes, evaluation notes within their EMR system, they will then have to translate that into the injury surveillance system. So there is a point in that kind of fine line between wanting to collect a bunch of data from other clinicians and actually having them collect a small and time-efficient amount of data so you get that buy-in. Are there any other kind of barriers that you all might see, or any other opportunities that you see for doing more local level clinician-based or practice-based research?
I think the barrier that always comes up is I don't have enough time, and a lot of people would say, like, I don't have time to try to do extra research. I'm on my own. I have to work with 100, 200 athletes. I have to cover the field practice, and in my opinion, if you have a bunch of injuries going on and you can prevent them by doing research ahead of time, then you'll actually save yourself time with the people you have long-term rehabs with the individuals who get with the more common injuries that occur over time. And if you implement the research that is done, or you develop research on the most common injuries that are occurring within your practice, you can prevent the excess time being spent on those individuals and improve your overall efficiency.
So question for you really fast. And just kind of talking to you, I know that working with the drum corps, your life is pretty much nonstop, correct?
Yep.
So, and let's say that you moved this to that group of other athletic trainers with different drum corps companies throughout the United States. If you had asked them maybe to collect, just off the top of my head, 3 different range of motion measurements for the ankles and input them into maybe an injury surveillance system or a data collection system, how could you convince those other athletic trainers or prove to them that it's worth it to spend maybe 2 extra minutes per athlete on doing that? So I know you talked a little bit about the benefit, but how would you convey that benefit onto the other athletic trainers so they would help you out with creating that practice-based research?
I think that comes from injury tracking, which is why this is injury tracking is becoming very prevalent among athletic trainers and athletic training in general, where you can see where the high end of injury is coming from, and look into measures of how you can possibly prevent it. And one of the more common injuries in drum corps is Achilles tendonitis or patellar tendonitis, mostly in the lower extremity. And overuse injury due to changing direction quickly, or bounding, leaping, a lot of the choreography that goes into the drum corps while they're jazz running, moving. So I think I would go and I would try to find that injury surveillance data that's been collected, the individuals who have that research, find that data and prove, hey, this needs to be fixed, this needs to happen. This is a measure that we could take to see what the incidence is within your group, measure it now, figure out what the percentage is, and then figure out if there's a method of fixing it by improving these measures.
Excuse me. So it sounds like a little bit of an education piece about how it can benefit them in their clinical site. It's one of that strategies that you would use to try and get them to buy it.
Mm-hmm.
I mean, to decrease injury rate, mostly. Like, if you're going to spend a lot of time, which we don't really have a lot of time, your breaks are treatment, and your lunch break is time. You're out at the field covering if there's an injury occurring, then you're there treating it. So the majority of the time you're either spent treating injuries or maintaining ones, making sure they don't get any worse. And the maintenance is the main issue, because if an injury occurs, it occurs. A lot of the time you can't prevent, if someone catches a rifle wrong, but if someone gets injured because they're overusing an area that could have been strengthened or benefited in another way, then that would be an area where you could prevent the injury and then not have to spend as much time with many individuals who have the same injury. So it would be more of, this will save you time, this will save you stress, it will help your individuals and members know that you're involved and wanting to be involved within their care. And I think that's something personally that's helped with my rapport with these performing arts athletes. Is I came in immediately and I said, hey, I know this is prevalent, and I know that you don't like it, and I know that it's going to take a lot of time to heal if it happens. So what I'm trying to do now is help you not get hurt in the future. And they're all like, yeah. So the buy-in there with the members wasn't very difficult. I think it would be buy-in for the athletic trainer actually, or the individual to actually implement it. They're going to get great buy-in from the individuals because it's an emerging setting. The kids are like, wow, you're giving me a Band-Aid for free? What is this? You know, so it's the concept of just taking the time to save yourself time later to prevent further injury.
Wonderful. So we talked a little bit about how we can get other clinicians involved in some of this translational research. Carolyn and Rachel, what do you think some barriers would be, or some ideas that you might have to get more research-oriented individuals, how to work on that relationship, on that end of the translational research spectrum?
Meaning, like, what do you mean by that? Like, I'm trying to think of what kind of barriers, as in, like, trying to make those connections and basically getting involved.
Yeah, so let's say that in your practice-based research you identified maybe a correlation between a specific screening tool and prevalence of injury. Mm-hmm. How could you work on a relationship between maybe actual laboratory researchers, mm-hmm. individuals who do some of those more succinct studies outside of the practice-based research? How could you create like a connection between that on that spectrum of the translational research?
I think to advocate for, like, say I, like you said, I see a need, I see a connection, and I want to convey it to them. I think definitely, like Nico was talking about, that injury tracking and kind of showing how, you know, what kind of injuries we're having, and maybe, you know, those kind of consistencies, and preventing or providing that information to them, and basically doing the same thing, doing the education part with those researchers, to then show them essentially, you know, this problem that you're now seeing, and you want them to create an actual research for, to help give you evidence for it.
Definitely, I think that's the one thing that I could really hit home on. I think when you look at the translational research spectrum, you see the researchers and you see the clinicians. Mm-hmm. And I really think that if you want that relationship to go both ways, on the clinician side of things, you really need to focus on some of those PBRNs to build up a foundational basis of evidence to create correlations and see relationships. So that way you could send that information back along the line and say, hey, here's a major problem that we want to see. We're seeing it in clinical practice. We want some more concrete information about this. This is a topic that we want to see researched, and then that relationship can continue on in the opposite direction after the findings are had. Moves back over to the clinician side, the application happens, and I think that that's really a good relationship in which researchers and clinicians can both benefit in pushing healthcare professions forward. Carolyn or Nico, do you have anything to add to that?
I mean, I think you guys hit a really important point. As it a little bit more, the clinician and researcher relationship, it needs to be two-way, so that the researcher can give us evidence and we can implement it into our practice, but then as we implement it, if we see other things that need to be looked into further, we hand that information back to them. So it's a two-way street, and information needs to be going both directions.
I agree.
Definitely. Nico, anything to add?
No, I'm pretty confident that we did really well discussing that topic.
Wonderful. Well, if no one else has anything to add for the good of order, I think that we will conclude our little podcast for today. All right, thank you all for joining, and have a wonderful evening.